neuropathy research. Before we begin, I wanted to let you all know that a recording of this presentation will be emailed to you tomorrow. We will also upload the webinar recording to the Foundation for Peripheral Neuropathy's online media center, where it will be permanently housed to our premium members to access. Today's presentation will last approximately 1 hour. It will include a question and answer session at the end of the panel. Feel free, however, to submit questions at any time during this presentation. You can do so through the chat box, which is located on the platform's dashboard. If you have any problems with the audio, specifically with your computer, feel free to consider using a telephone to dial in. Those instructions are located in the email that you should have received within the last hour, including a link to this platform and to this session. And lastly, I'd like to introduce you to today's presenters. First of all, my name is Lindsay Colbert. I am the Executive Director here at the Foundation for Peripheral Neuropathy. Also joining me today is Nancy Froman. She is the Foundation for Peripheral Neuropathy's Director of Development and Marketing. Today's panel moderator is Lou Mazway. He is the Foundation for Peripheral Neuropathy's Board President. Lou is a practicing lawyer out in Washington, D.C., and is personally affected by peripheral neuropathy. He has a relatively rare autoimmune disorder associated with anti-MAG. And we're thrilled that he's not only this organization's leader, but we're also pleased that he'll be leading today's discussion with our 3 experts. Those experts include Dr. Gordon Smith, Professor and Chair of the Department of Neurology at Virginia Commonwealth University. Dr. Smith's focus on peripheral neuropathy and diabetes and obesity, and he has a particular interest in biomarker development and novel clinical design in peripheral neuropathy. Dr. Smith sits on several boards, including the Foundation for Peripheral Neuropathy, and he's a valued team member of ours. And thank you, Dr. Smith, for taking time to sit on this panel. I also welcome Dr. Sunda Ajudris, Associate Professor and Neurologist at Northwestern University in Chicago. Dr. Driss also sits on the Board of Directors at the Foundation for Peripheral Neuropathy, and she's also the Principal Investigator at Northwestern University for our top research program, the Peripheral Neuropathy Research Registry. Thank you again, Dr. Driss, for being a part of today's discussion. And lastly, I'd like to introduce you to Dr. Amit Hoke, Professor of Neurology and Neuroscience and the Director of the Neuromuscular Division at Johns Hopkins University. Dr. Hoke is the Chairman of the Foundation's Scientific Advisory Board and is also the Principal Investigator at Johns Hopkins for the Peripheral Neuropathy Research Registry. And he's going to be talking in greater detail about that during today's session. Dr. Hoke has been an irreplaceable expert for the Foundation, and again, we're thrilled that he's joining us today. And at this time, I'd like to turn the microphone over to Lou to get our panel discussion started. And I also invite the panelists to join us at this time. All right, Lou,
yep.
Take it away.
Yeah, thank you, Lindsay. It's my pleasure to moderate this distinguished panel of experts and the Foundation. You know, we're extremely fortunate to have these 3 panelists on our boards that are leading experts nationally in the field of peripheral neuropathy, and the Foundation. We're also very grateful, obviously, to have for our generous donors who are in the audience today for sponsoring this and all the other work that we do. So I think we're going to start. We have sort of 3 groups of questions, which we're going to each panelist is going to moderate, you know, kind of take the lead, but then each of the other folks will be able to join in and share their thoughts for the benefit of the audience. So Gordon, the first question today is, you know, the predominant cause of peripheral neuropathy is type 2 diabetes. And so there's a lot of interest in what's going on in the field of research for diabetic PN patients today.
Yeah, well, thanks, Lou, and I guess thanks for including me in this event. These are always fun events, and look forward to questions from our participants. There's a lot to unpack in that question, right? There's a ton going on, and just to emphasize, diabetes is running away the most common cause of neuropathy. I say running away. Idiopathic neuropathy is probably a fairly close second. And I think, to answer the question of what's going on, in my mind, is best answered by thinking what questions we have about diabetic neuropathy. And I think of these as sort of, how, why, what kind of a question. So how is it that people get neuropathy and diabetes? And there's a tremendous amount of work going on to understand that. And Ahmed is a translational neuroscientist, so we can get Ahmed to give us an update on kind of the basic science of this. But I really think that the answer, a cure, as it were, is going to be founded in work going on in laboratory science, and that's something very important for us to support. We have learned a lot over the last number of years. A simple concept that wasn't so apparent maybe 15 years ago is that the neuropathy in patients who have juvenile onset or type 1 diabetes is very different from the neuropathy in type 2 diabetes. The end state may look similar amongst patients, but the mechanisms are likely different. And I guess the other point to be made about neuropathy is, my hope is if we can figure out one, we'll figure out many, so to speak. And so the concept that what we learn from disease mechanisms and other kinds of neuropathies, whether they be inherited or chemotherapy, may inform how we go about treating diabetic neuropathy. One of the questions that, certainly has puzzled me for a long time is why do people get this and some people don't, right? So only about half of patients who have diabetes get neuropathy. And so if we can understand why some people do and why some people don't, that would be helpful. We've learned a lot about disease risk factors. It turns out that the same sorts of things that are risk factors for lots of medical problems, including heart disease or stroke, are also risk factors for neuropathy in both type 1 and type 2 diabetes, and these present therapeutic targets. Another is, some people are probably genetically predisposed, and I'll emphasize the importance of the Peripheral Neuropathy Research Registry, which I know we'll talk about many times, which is, the Foundation's main ongoing research effort. This is going to allow us to understand genetic determinants of neuropathy risk, or what kind of symptoms people have. Why do some people get pain, and why don't others get pain? There's other work going on looking at what's happening in the brain. We think of diabetic neuropathy as a peripheral nerve problem, which it is, but if you do sophisticated brain imaging studies in patients who have painful neuropathy, for instance, you can find differences in how their brains are processing pain information. And so all of this in aggregate leads to a lot of ideas about how we can do, I think, three things. And so the first is, how nice would it be to be able to prevent diabetic neuropathy? And so we know in other fields like Alzheimer's, for instance, we can really reduce Alzheimer's risk by just paying attention to risk factor modification, a healthy diet, exercise, stop smoking, control your blood pressure, and so forth. And we think those same strategies are likely to help in preventing diabetic peripheral neuropathy. There are people working on ways of how do we screen people for diabetic neuropathy? So I think everyone's familiar with the concept that diabetes not only causes neuropathy, but also eye problems. And we've been able to revolutionize prevention of blindness due to diabetes by just screening and then implementing early treatment. And there actually are techniques, one of which looks at the nerves in the surface of the eye, that might have application there. And then how do we go about treating neuropathy? And this is really two different questions. One is how do we go about disease modification? In other words, take someone who has neuropathy and either reverse it or prevent it from getting worse over time. And there are certainly clinical trials looking at innovative approaches to this, some of which converge on inflammation. There's even a gene therapy-based trial going on. Then the other area of active investigation is how do we manage symptoms? We in particular pain symptoms. We have relatively few pain medicines that are really effective in diabetic neuropathy. I think one thing that, just a shameless plug for our own work, but I think others are quite interested in this area, and it's something everyone can do, is the importance of just basic lifestyle modification, that is healthy diet and regular exercise. And our experience, and I think every study I've ever seen looking at this, has found that if you can get people exercising and eating a healthy diet, their neuropathy is much more easily managed. So that's a long answer to your question, Lou, and we could unpack individual aspects. And I think it'd be interesting to see what Dr. Hoke has to say about basic mechanisms and what are the promising treatment targets of the future.
Right. Well, thank you, Gordon. Great. So now I guess the next, and as you mentioned right sort of at the beginning, Gordon, the second most common cause, so to speak, of PN is the idiopathic group, and that's millions more folks. And is there a lot of research going on for that cohort of the PN community?
Yeah, so when I'm talking to patients about this, I always like to reflect about a patient I had at the last institution where I worked, who, after I told him he had idiopathic neuropathy, he looked at me and said, that must mean you're an idiot because you can't figure out my neuropathy. So it's a funny term. So the challenge of studying idiopathic neuropathy is almost by definition a none of the above category. And in particular, studying the same thing. And if you view idiopathic neuropathy as none of the above, it's probably not all of the same thing. I think our thinking about idiopathic neuropathy has really evolved over the last 2 decades, with the observation that most patients who have idiopathic neuropathy have these same risk factors I mentioned earlier. So they overwhelmingly have metabolic syndrome, which is a combination of being overweight, having pre-diabetes or diabetes, high blood pressure, abnormal lipids and cholesterol and the blood. And it's likely, I think, that idiopathic neuropathy is a result of these multiple risk factors. And surely there are going to be some people with idiopathic neuropathy who have other causes, but I think it's that recognition that's led to the beginning of treatment development. So we're actually about halfway through with the first large-scale clinical trial of a treatment that's designed to slow the progression of idiopathic neuropathy. This is funded by NIH and is looking at actually a medicine that's been available for quite some time, topiramate, which is used for headaches and epilepsy, but it actually causes weight loss and blocks sodium channels, which are pores in the cell that allow sodium to pass back and forth, and are likely important in particular pain generation. And so that's exciting, and I think it's opened the door to new clinical trials in this space. The last thing I'll say about that is if you buy the idea that idiopathic neuropathy in most patients, or at least many, is a reflection of what we think of as cardiovascular risk factors, it really ties it very closely to the neuropathy and type 2 diabetes. So the study which I just mentioned, which is called TopSpin for topiramate for cryptogenic sensory peripheral neuropathy, is enrolling patients who have idiopathic neuropathy, but also mild diabetic neuropathy, which I think is likely a shared, two disorders that have a shared mechanism.
Right. And so now thanks for mentioning the clinical trial and that study. I mean, how do folks get, let's say that, patients want to get involved in clinical trials to help themselves, help along the research process for future, patients. How did people do that?
So I think the question you're asking was a really great one, and I actually would back up and think about it a little more broadly, which is how can patients partner in finding a cure for the disease that they have. There are multiple ways of doing that. To your specific question, participating in clinical trials is absolutely essential. And I would say we have a lot to learn from cancer, not the disease, of course, but cancer centers. So I think most people are familiar with the idea that there are National Cancer Institute designated comprehensive cancer centers. And one of the metrics by which these centers are judged is the percentage of patients that are participating in research. And the intent is that research is really a collaborative, shared exercise with patients. And I think that's something we really need to engage all our patients and think about. And it's easy to see what clinical trials are going on in a particular area. There's a website, clinicaltrials.gov. All you have to do is type in clinicaltrials.gov, and any clinical trial that's ongoing, or for that matter in the past, really is listed there. So easy to see what's going on, and you can see what trials are in your area. I think keeping up to date on that, and then having a conversation with your care provider, your doctor, or advanced practice clinician who's seeing you is important. But I think there are other ways of partnering. At the simplest, we all learn from our patients. And I have a colleague who, we were at a donor event, and she referred to the person who we were honoring as her muse, that he inspired her to do the research she was doing, which has been very successful. She just got a new NIH grant focused on that. And then, of course, at the beginning of this, we acknowledged our donors, and I think donations of time, ideas, and frankly inspiration is really important. So there are lots of ways of becoming involved. Coming to things like this and being involved with the foundation is an obvious one.
Yeah. Well, thank you. Thanks
and
a lot.
participate in the registry. If you're live in a community where there's a PNR site, I would definitely participate in the registry.
Yeah, well, that's a perfect segue to and before I go to I mentioned, when the foundation becomes aware of trials, Lindsay and Nancy will put them up on the website to make them, but obviously we don't screen all of them and notify folks about all of them. But so you oversee the PNR at Johns Hopkins there. We really appreciate all your great work. So what is it? What are the important things about the Foundations Registry in your view?
Yeah, I think as Gordon mentioned, the oncology field is way ahead of us in terms of partnering with patients and carefully studying their disease. So years ago, when the foundation wanted to embark on a research, the consortium sites, we asked for this natural history study because, as Gordon said, we probably know a lot about diabetic neuropathy and some of the other types of neuropathies, but idiopathic peripheral neuropathy, we really don't know much. We don't know the risk factors. We don't know what causes it. And so unless you know about it, it's very difficult to come up with treatments. So that was really the impetus for the PNR, the registry, to better understand the patient's symptoms, the examination findings, and the associated laboratory findings to determine risk factors for developing idiopathic peripheral neuropathy, and also banking blood samples so that we could do future discovery research, which is ongoing, as you know, in the field. So in a sense, this is basically a catch-up to other disease areas. For example, in Alzheimer's disease or Parkinson's disease, there are natural history studies similar to the PNR where they're able to better understand the patient's symptoms and examination findings.
Mm-hmm. Yeah, thanks a lot. So so maybe you can give us some examples of research projects that are currently being worked on or recently done using samples of the data in the PNR.
Yeah, so the most important thing is really one, to understand causes of peripheral neuropathy, and the second thing is to better understand pain, which is probably the most important symptom for patients with peripheral neuropathy. There are a couple ongoing studies that are being done with the blood samples that are collected with the idiopathic peripheral neuropathy patients. One of them is looking for unknown genes, so we can actually sequence a patient's all of their genes and look for new mutations in genes that might put them at higher risk for developing idiopathic peripheral neuropathy. The second one is what we call a biomarker discovery research that is ongoing, where we're basically looking at different proteins, lipids, as well as metabolites in the blood samples of the patients with severe pain versus no pain, and comparing those to identify abnormalities in the blood that correlate with the increase in pain state in these patients. Hopefully these studies will lead us to better understanding of what might be causing pain in peripheral neuropathy patients. As you know, not all patients with peripheral neuropathy develop pain, and we really don't have a good understanding of why that's the case and how we can better understand that. And then finally, there are a bunch of what I would call clinical studies, descriptive studies that are being done with the patient characteristic that we correlate, that we collect. One of them is a recent look into the role of exercise. And although exercise has been shown to prevent progression or at least slow the progression of peripheral neuropathy in diabetic patients, that had not been studied in idiopathic peripheral neuropathy patients. And when we looked at our database, and we found that the patients who exercised regularly had less pain and less severe peripheral neuropathy compared to the ones who weren't exercising. And this is for the idiopathic peripheral neuropathy group. So obviously this correlation doesn't mean causation, and we will need to randomize patients with idiopathic peripheral neuropathy to 2 different groups to see if exercise truly slows the disease progression or not.
Mm-hmm. Yeah, that's very helpful. Thank you, Ahmet. Yeah. And now, so how the PNRR is still ongoing, right? Where the institutions are still enrolling patients. I mean, there was obviously a little stop there, a little more than because of the COVID, 19 research, slowdown. But once it resumes, and if it is resuming, I think in a few places, how do they go about getting into the registry?
So it's true that during the COVID early months, no clinical research were allowed, but as of June, at least at Johns Hopkins, we have started seeing patients in person again, and we're allowed to enroll new patients to the PNR. And so basically, the patients who are interested in participating in the PNR will need to contact one of the consortium sites and be seen in their regular neurology or peripheral nerve clinic as a regular visit. And during that time, they will fill out a detailed questionnaire about their symptoms. A standardized neurological examination will be done, and blood samples will be collected. Lou, before you switch over, I also wanted to comment on the common drug discoveries that Gordon mentioned. One of the questions was what's happening new in the field, and one of the realizations in the last 7-8 years is that most peripheral neuropathies, the ends of the nerves, probably degenerate using a similar molecular machinery that is called Wallerian degeneration. The molecules involved in Wallerian degeneration are also playing a role in nerve degeneration in diabetic neuropathy, in chemotherapy-induced or HIV neuropathy. So there's a strong interest from several startup pharmaceutical companies trying to develop inhibitors of this pathway so that we can actually come up with a drug that will work across multiple types of peripheral neuropathies. So I think that's really I know it's very early stages right now. It's at the drug discovery stage, but there are some interesting leads that hopefully will be moving into the patients in the next 2 to 3 years.
Very good. Thank you on that. Yeah. And I think, and the sites that participate in the PNR, they're on the website for the Foundation for PN, so you can go on there and find out
Exactly.
about them. Right. So thank you. So now maybe, Ahmet, we'll move on to Senda. And Senda is going to focus, a lot of folks have been concerned about COVID-19, the impact on, does it make us more likely to get, COVID-19 if we have PN, or if we have PN, harder to deal with the, the treatment. So Senda, we appreciate your thoughts on, and how has it initially impacted your practice there, the coronavirus pandemic?
Hi, Lou, can you hear me?
Yeah.
Perfect, very well. I apologize, everybody. I'm not able to have to access my camera, so there is no audio, there is no vision for me, just the audio. Well, this is a very good question, Lou, and we were all kind of what we used to do was brought to a halt very quickly with COVID-19. But with everything, there is always a silver lining. So as you know, with the lockdown, people could not go to hospital. We couldn't see our patient. But we had to take care of our patients. So what we did and what worked really quickly is establish telemedicine very quickly. Over the years, we were trying to establish telemedicine. It wasn't easy, but in a way, I have to say, thanks to COVID, almost overnight, very quickly, we were able to deploy telemedicine across the country almost, and we were able to see patients from all over. I can say that we continue to take care of our patients as best as we can, and this actually opened up new opportunity for us. It allowed people who were living far away to be seen in clinic when they couldn't before. So this is one thing. I mean, of course, it's initially everything stopped and we had to kind of figure out how to do things. But really, the opportunity of telemedicine was a game changer, and it kind of opened many doors for us. And I think telemedicine is here to stay. There were many issues initially with billing, with multiple other kind of administrative difficulties, but we were able to overcome those very quickly and really realize that people were more tech savvy than we gave them credit to. Of course, it does help that many platforms are available now, and we could sometimes even in a one session troubleshoot and go from webinar to Doximity to Zoom, depending on what the internet connection is and how best to do things. It is ironic that I'm not able to connect today through the camera, that's what I have been doing for the past almost 6 months. It is nice. It is nice to be able to work from home. It's a concept for us physicians that is completely unknown. So it's new challenges. Of course, I mean, seeing a patient through a camera is not ideal. We do miss many things. We do address a lot of things. We can be efficient. It works very well with very known established patients that have very limited issues. It's very difficult to see new patients through a camera because, of course, you can't do a very comprehensive exam. It helped us to kind of troubleshoot that as well, to think of an innovative way to examine patients through cameras. We are now teaching our medical student, resident, and fellow how to think outside the box and to kind of be able to look for things, for signs through a camera rather than examining patient directly. So it's all a new way to kind of teach medicine in the future. The nice thing also about the COVID, it made meeting from all over. I mean, it changed the way we do scientific meetings. It changed the way we all meet. In a way, we can do it with everybody at the drop of the hat. And on the other, the downside of that is actually we miss on the networking with our colleagues. So We try to adapt the best we can, but really these brought a whole new set of new ways of taking care of patient, of following on scientific developments, and so forth.
Yeah, that's great. Well, you know, like I said, silver linings out of so many things, but you know, obviously good and bad. And what kind of, and so when you see a PN patient that's contracted COVID, what is there a connection there, or they just have the normal COVID-19, you know, normal in quotes, you know, symptoms with smell and taste and breathing and things like that? What have you seen there, Sandra?
So it's interesting. As a neuromuscular specialist, I haven't been directly impacted by COVID. Not many of my patients have had COVID. However, and we do, the way it's managed in my in my institution is patients who had COVID are seen through what we call the post-COVID clinic. And most of these patients don't necessarily have a neuromuscular disease, but in a pandemic that affected almost 8 million people would at some point will affect a patient with peripheral neuropathy, for example, or other neuromuscular disease. So as you know, COVID has multiple phases, and I really want to emphasize that although we've been in this pandemic for at least 6 months, there is still a lot of things that we don't know about this disease. We're really discovering things every single day. We don't know what the impact of having COVID is on the brain as a whole. You know, initially we were very worried about patient living, right? It was patient will go to the emergency room, and the next thing you hear, they're in the ICU intubated, and there is problems with that. So we after that acute phase, it appeared like now, for example, there is less death, and the fact that patients go to that they don't go to the emergency room as they used to before, and they're not admitted in the ICU as often. Do we know more about it or no? We're trying to debate that. So what happens with this disease, as I said, it has multiple phases, and some people will don't even know they have it. Some people will have a very mild disease, and some people will have a more severe symptoms. The thing that's coming that we're trying to learn a little bit more about is what we call this new thing called the COVID long hauler. Those are patients who will catch COVID. Usually it's a little bit more severe, where they either go to the hospital or really they have a lot of bad symptoms from it. And after they think they turn the corner, they don't really get better. They continue to have symptoms. They're very tired. They have difficulty concentrating, and they have problem with their stomachs. There is so many other things that prevent them from having a normal life. It's not like you get the flu and then you're done, and you maybe a couple of weeks later you're back to where you are. It seems that these people have a hard time going back to where they are. And we don't know what brings this on. I mean, we know that people over the age of 50 with more severe disease tend to have it, and we don't know what it is. I mean, is it a low-grade inflammation? We have really no idea. It's being looked at right now. So you can imagine if a patient with a peripheral neuropathy will get COVID, I mean, they could recover without knowing. They could have mild symptoms. They can have just the loss and smell and taste. But the fact that there is a pre-existing condition and the fact that they may have a more severe disease, if they are left with this long hauler that we call, you could understand that it's going to make life a little bit more difficult. It may make the pain from the neuropathy a little bit worse. It may make the symptoms of the neuropathy, the numbness and so forth, worse. This is pure speculation on my part. We really don't have the data that will support what I'm saying, because we're still trying to learn about this disease. Having peripheral neuropathy does not place patient in a category where they will be more likely to catch COVID. No. The other problem with patients with neuropathy is they are, as Dr. Gordon said, more likely to have the metabolic syndrome, more likely to have a diabetes, And we know that for patients who have diabetes, if they or are a little bit obese, if they have COVID, they tend to have a worse kind of prognosis than people who don't. So you can understand how that also could make things a little bit worse.
Right, sure. Well, I think so. I guess my guess that was all very helpful, Cinda. And so I guess, have you seen any new PN patients that have come to you after, they had COVID-19, maybe they had a mild case or maybe not so mild? Has many of those patients come forward yet?
So yeah, we were kind of expecting that. I mean, there is a case report of patient getting Guillain-Barré. Guillain-Barré, you can see it after a flu, after any immune kind of or any viral infection. We were expecting to see more Guillain-Barrés with COVID, but we haven't. There is few cases that have been reported in the literature. I personally haven't. I mean, I'm going to ask Dr. Gordon and Dr. Hoke if they did. I have not seen somebody develop a peripheral neuropathy after COVID. What we have seen, though, because in patients who were in ICU and they were placed prone, for example, on their stomach to help with their breathing, these patients were subject to a nerve compression in their arms, and they seem to develop more problem with their nerves in their arms, like they had more weakness and numbness in their arm, for example, or sometimes in their leg because of the way they were positioned in the ICU. So there was more pressure on these nerves. So that's what we've seen. About 14% of the patients that were admitted to our rehabilitation institute, the Shirley Ryan Rehabilitation Institute, seem to have an increased risk of this. But not the neuropathy that we think of usually, the numbness and the tingling that happen in both feet at the same time. Usually these kind of develop more slowly over time. I haven't seen them really related to COVID in any way. But I would like for Dr. Hoke and Dr. Gordon to comment on that if they have seen it.
Oh, yeah, thanks. Gordon, Ahmet, that's Ahmet, yeah. Have you seen much?
I mean, I haven't seen any like Senda, and the ones I have seen have been compression neuropathies.
Yeah, we've seen a small number that range from typical Guillain-Barré syndrome in the setting of recent COVID infection to I've seen a relatively acute onset CIDP with the neurofascin antibody after what we weren't able to confirm it, unfortunately, because it was after the fact, but sounds like COVID. So I would say it's not common, but definitely described.
Yeah.
I would echo that the risk factors for neuropathy are also risk factors for, a more difficult course with COVID.
Right.
So we certainly talk to our patients who share these risk factors about the need to be particularly careful in trying to prevent exposure, managing risk.
Yeah. All right, thank you all. So now I think we have a lot of questions. We'll start to go through as many as we can. We have a good 20 minutes. So the first one is it concerns what promise does stem cell research hold for the treatment of peripheral neuropathy? That's been a hot topic in so many medical conditions. So you want to start, Ahmet, or you want to?
Sure, I'm happy to do it because this is an area that actually I studied in the lab. And, if you had asked me this question 15 years ago when we first started, I would be very optimistic. But after 15 years of research in the area, I'm not so much that stem cell transplantation is going to be a proper treatment for most peripheral neuropathies as we think of. It may have still some limited role in patients who have nerve traumas and needs nerve grafts. And theoretically, you can put stem cells in there to help the nerves regenerate better, but not for typical peripheral neuropathies. Where it's going to be helpful actually is better understanding the genetic neuropathies. So we could now take a skin sample from a patient with a new mutation, for example, or a rare type of inherited neuropathy, and convert those skin cells into stem cells, and then study and then take those into neurons, nerve cells, and study how that mutation affects the function of the nerve cell. And that helps us in terms of better understanding of the disease, and also serves as a platform to test new therapies before we can take it to patients.
Thank you. Gordon, Cindy, you want to elaborate on that?
I agree with Ahmed. I would also point out that there are stem cells and there are stem cells. It sounds like something Yoga Bear would say, but a lot of time what patients are seeing in advertisements or marketing as stem cells are not the same stem cells that Dr. Hoke was studying in the lab, and one needs to be really careful about these sorts of practices. The federal government has actually been actively investigating and trying to tamp down on the investigational use of stem cells in this setting. And so I would encourage people to be very mindful before they embark upon stem cell therapy. There have been complications of this, and before considering, I would certainly talk to your neurologist about the wisdom of that.
I would like to add that we talk about stem cell loosely. In immune-mediated neuropathy like CIDP, we have used stem cells, but these are patient-owned stem cells to kind of reboot their own immune system. So it's the stem cells in themselves don't have any role in helping with their neuropathy. They just help reboot their immune system, so they're not in a state of low immune system and can catch any germ that is out there. So I just want to clarify that as well. Patient, when they read, they think this is the stem cell that everybody else talk about, but this is really different and used in very specific autoimmune situation.
Thank you, Sandra. Yeah. So our next question, I know this is going to be, do you have something else to add, Ahmed? Did you want to? No.
No, I mean, I just kind of say that that's basically bone marrow transplant, autologous bone marrow transplant. So that's a term that the patients are going to be familiar, and not really a stem cell treatment in the sense that most people think of stem cells.
Right, absolutely.
Thanks. So the next one, I know this is going to be, going to have a lot to say on this. Can you talk more about prediabetes and metabolic syndrome as factors in PN, which I know
Gordon.
Who wants to start? Gordon, the specialist on this.
Yeah, how long do you have?
Well, it's not funny, but I mean, it's a very common.
So, I mean, the story of this is actually sort of interesting. Old dogma had it that one didn't develop neuropathy and diabetes until many years of poorly controlled diabetes. And that was certainly the school of thought when I was a medical student and even as a resident. It was actually, as I was doing my fellowship training, we started to make the observation that probably many others had already made, that patients who had idiopathic neuropathy, who didn't have diabetes, looked diabetic. You'd see a patient who had burning feet, who was overweight, had high blood pressure and a high cholesterol, and you think, well, gee, they should be diabetic, and they weren't. And over time, it became apparent that patients who have otherwise idiopathic neuropathy have a higher risk of having prediabetes or metabolic syndrome. This was very controversial at the time and really challenged traditional dogma, even though looking back at older data sets, this isn't really a new discovery. I think what's changed over time is the recognition that these are, I think of them as more risk factors, and it's likely that the downstream disease mechanisms that take place in type 2 diabetes are shared with what we see in patients who have multiple kind of cardiovascular risk factors like this. We see the same risk in patients who have diabetic neuropathy. So patients who have diabetes who have these other risk factors are much more likely to have neuropathy. And it's likely controlling them is important in disease management. So in type 2 diabetes, really aggressive control of the glucose doesn't reduce neuropathy risk all that much. Obviously, you have to do it, and it does help some, but it's very unlike type 1 diabetes. And that's likely because in type 2 diabetes, the drivers of neuropathy progression over time are not just the diabetes, but these other risk factors. And the last thing I'll say, and the answer that I'm sorry is too long, is it's likely these risk factors are relevant in other forms of neuropathy. So we have data now that adds to others that in chemotherapy-induced neuropathy, patients who have these same risk factors, so metabolic syndrome and diabetes, are more likely to get peripheral neuropathy following chemotherapy or neurotoxic chemotherapy.
Yeah.
That was shorter than you thought it was going to be, Ahmed. I can tell you.
Yeah. Ahmed, Sandy, you want to add anything to that good discussion? No. So we have a next question is on this person has large fiber PN and they don't have pain, but they need to wear AFOs to walk in order to, and is it generally true that, so this background for the question, is it generally true that small fiber PN has pain and long fiber PN does not? Associated. Sandy, yeah.
I can take the question. That's actually interesting what you're asking. So large fiber and small fiber help transmit pain, touch. Those are different kind of type of fiber that help us feel in any way. And the very small fiber, they are important for feeling pain and temperature, whereas the large fibers are very important for our balance. So yes, you're right. Sometimes people who have what we call a small fiber neuropathy may have more kind of the burning feeling, and people who have just the large fiber may have more of the balance issue. Sometimes people have a combination of both. In a large fiber neuropathy, there is loss of balance, but it's also loss of feeling. So people will complain of numbness or feeling that they're walking on rocks, for example, or they have cotton at the bottom of their feet. So that's the kind of a little bit of a distinction between the two. I don't know, did I answer the question or?
I think so, but yeah, I mean, it sounded like it could be, the person asked is generally true, and I guess it is generally true, but there are always exceptions, right? That there are.
Yeah, and the exceptions is actually a relatively large number of patients. For example, a typical one is inherited neuropathy, CMT1A, which is thought to be a demyelinating disease that affects large fibers, but up to 30 to 40% of the patients also have pain in addition to muscle wasting and balance issues. So I think the involvement of small fibers and therefore pain is relatively common even on the so-called large fiber neuropathies.
Yeah, I'll just add to that large fiber predominant neuropathies are a common cause of painful neuropathy. So if you look at a group of patients who have painful neuropathy, only a small minority have an isolated small fiber neuropathy. And so I think, and there's mechanistic reasons why injury to large fiber myelinated sensory axons can cause neuropathic pain.
Yep.
Yep. Thank you. So are there any, next question, are there any new drugs in the market or the pipeline to help stop PN from starting or progressing?
Can I take that question first? So as I mentioned earlier, this whole pathway that has been identified, the molecules in Wallerian degeneration, really changed the field. So one of the key molecules in that pathway is a molecule called SARM1, SARM1, and inhibiting this molecule or genetically deleting it in mice basically prevents diabetic neuropathy and many different types of chemotherapy-induced peripheral neuropathy. So the drugs that are being developed to inhibit this enzyme are probably the first ones that are going to get into the clinics to prevent disease from progressing and from developing in the first place. The first clinical target is going to be chemotherapy-induced peripheral neuropathy, because we know when the patients are going to get their chemo, we know when they're going to develop their neuropathy. We can actually give them this drug before they get their chemo and kind of prevent the neuropathy from developing in the first place.
That's really great. Yeah. So, and then to kind of related, maybe how can a patient slow the progress of their PN? You know, what's the main advice that you would give? And
So Luke, can I go back to the prior question?
Yeah,
Because
sure.
Amit's answers the first one that comes to mind, and very exciting development that impacts multiple forms of neuropathy. But you know, there's been a revolution in molecular therapy, gene-based therapies for inherited and some of which devastating neurological diseases. So not a peripheral neuropathy, but we've seen what looks an awful lot like a cure when given early enough for spinal muscular atrophy, which is a fatal infantile disease with one of a couple of different gene therapies. And these technologies are being developed all across medicine, and in particular genetic neurodegenerative disorders. So think Huntington's or hereditary forms of other neurodegenerative diseases, ALS, for instance. And I think it's likely that we're going to see these same, in fact, we've already seen these same technologies in inherited neuropathies. So, you know, we now have 2 molecular therapies for hereditary neuropathy due to a mutation in the gene, leads to amyloidosis in the transthyretin gene. And so I think we're likely to see more of that. These are rare diseases. So, you know, the number of people who have any one of them is going to be relatively small, but there's 7,000 rare diseases, believe it or not, and 10% of Americans have a rare disease. And Lou has a rare cause of neuropathy, and we're seeing a lot of interesting therapeutic development and inflammatory neuropathies. So, you know, we've been talking a lot about diabetes and idiopathic neuropathy and a bit about chemotherapy, but if you look more broadly, I think there's a lot of excitement in the pipeline. So sorry, I just wanted to.
Yeah, it's good. No, it's helpful. Thank you.
Yeah.
So the next, you know, the patient comes in and he or she has PN. What's the advice for them to slow the progress of their PN? And I know it depends probably on, well, what type they have, or maybe Sandy, you want to?
Yes, I can take that.
Yeah.
So you're right. It does depend on the type of neuropathy. Usually neuropathy is a disease that progresses slowly. What I usually tell my patient, and especially for the ones where we don't know the reason, like the idiopathic, for example, really keeping the body healthy, eating healthy, exercising is important. As long as your body is healthy, you're going to help make sure that the nerves are in an environment that is healthy. So even though they are sick, they will kind of have the best chance not to get sicker. Definitely getting the increase in weight, getting diabetes, for example, will be a disaster, because we know diabetes cause neuropathy. So that's going to make your neuropathy progress faster. And not just diabetes, even the glucose intolerance, as Dr. Gordon has been explaining. So really my advice is simple. Really, better kind of increase activity as much as you can. Walking is important, and eating healthy, limiting the toxins that we know for the nerves. Alcohol is a toxin. Having a glass of wine here and there is not going to be a disaster, but people who drink heavily really need to decrease the drinking. Simple, but it's usually easy to follow advices.
Yep. Anybody else, Ahmad or Gordon, you want to weigh in on that? Or I guess that's good general advice there. The next question is, and this is really technical, I could be, what causes the feeling of pain? You know, and some PN patients have pain, others don't. What is the cause of the pain?
Well, what I usually tell my patient, I'm sorry, Ahmed,
No, go ahead, Brenda.
Pain is really pain is important. We are human because of pain. If we didn't have pain, we would be injuring ourselves all the time. So it's a normal evolutionary mechanism. And pain is felt not in the feet, it's felt that actually in the brain. And because people have neuropathy, what neuropathy is, the nerve are unfortunately misfiring. They're sending wrong signal to the brain. So if you touch, you're supposed to feel the touch. But in a patient with neuropathy, when they touch, that touch signal is translated into something different, that is pain. So the pain sensation is happening because of this misfiring at the level of the spinal cord and at the level of the brain. It's not happening down at the level of the feet, for example. Go ahead, Ahmed, you had something else.
No, you summarize it. I always tell patients the reason they feel pain is that the nerve fiber that partially degenerated in their feet, the rest of that nerve is still connected to the spinal cord and to the brain. And when that nerve loses its touch with its target skin, it basically becomes electrically unstable and fires off electrical impulses to the brain when it's not supposed to. But the brain is going to interpret that as pain coming from that fiber, even though that fiber is now no longer connected to your feet anymore. Think of it as like the patients who have phantom limb pain. You know, they don't have a hand or feet, but they're going to feel pain as if they have a hand, because that nerve that's no longer connected to a hand is still connected to the spinal cord and to the brain. And when it fires off, brain is going to interpret that as pain coming from that particular body part.
Well, maybe this is a good next question. Thank you. Is what have that you experts seen in patients that have had an injury of some type, and then its impact on causing PN or the progress of maybe PN somebody already had? What's the connection there?
Yeah, maybe I can give it a try to answer this question. First of all, I don't think there is any data to suggest that a single injury or even repeated injuries can cause a diffuse illness like a peripheral neuropathy. But we have to be careful. We're talking about polyneuropathy, that is, it affecting both limbs, both feet, and so the progressive type of peripheral neuropathy. There are types of peripheral neuropathy that we call mononeuropathies, that is, just one nerve is affected, and those can be from traumas. And a classical example of that is actually carpal tunnel syndrome. So somebody who has pinching of their nerve in their wrist is going to have pain in their hand in the distribution of that nerve fiber. So the same thing with their legs. If they have a trauma, for example, car accident or something, and they injure their nerves, they're going to have a mononeuropathy in the distribution of that nerve. That's very different than what we're talking about when we say peripheral neuropathy, which refers to a more diffuse illness.
Okay. Yeah, thank you. And the last question, I think maybe this goes back to the PNRR. The question is, what are some of the possible answers that we think that can emerge from the research through the Foundation's PNRR? And obviously, hoping for better treatments or prevention. What are your thoughts on that?
Yeah, I think the primary goal is really to better understand idiopathic peripheral neuropathy, to identify causes of it, and also a better understanding of what causes pain in patients. So with those biomarker studies that I mentioned, we're hoping to identify abnormalities that tell us something about the chemical composition or protein composition that can be helpful in terms of why the pain develops in some patients and not in the others. And once you identify what is dysregulated, what is abnormal, then you can start thinking about, can we reverse it or can we change it to prevent the pain or to prevent the peripheral neuropathy? So we're really at at the beginnings of our discovery research for idiopathic peripheral neuropathies. And PNR is really the only game in town in terms of helping us do that.
Well, and that's really good, because I know so many people like in my PN support group that have idiopathic neuropathy, and they just feel like, they're kind of the lost souls. Nobody really focuses on their particular situation. So what you're saying there is very encouraging on that, I think.
Yep.
Yeah. Any other? So, well, thank you all very much. This has been great. And now I think, Nat, you're going to come on now, I think, to close out the program. And yep.
Oh, can you hear me now? Great. Thank you, Lou, and thank you, panelists, for such a great discussion. My name is Nancy Froman. I'm with the Foundation for Peripheral Neuropathy, and I can say that listening into what we learned today, while obviously it's a moving target, there are definitely advances being made, and it's hopeful for the future. I thank everyone for attending our event. I hope you found it as interesting as I did. We got to some of your questions. Some of the questions we didn't get to, we'll try to summarize and follow up with our experts at a later time and send them out. Like many organizations, we've been looking to this webinar platform to offer our educational programs for the rest of the year. So keep an eye out for more webinars over the coming months and into 2021 as a way to bring expert viewpoints on PN and lifestyle tips to more of you and more of our patients. Besides looking to be a source of information on peripheral neuropathy, FPN also remains focused on facilitating research, particularly through the Peripheral Neuropathy Research Register that was mentioned, as well as our other programs. There's exciting work being done, and we want to make sure that we're helping move that along. And your contributions help us do that. They help us facilitate research, help us bring these kind of programs to you and to others. And if you liked what you saw here, I would be remiss if I didn't put a plug in to say, please continue to support us through your donations. You can go to our website to make your donations. We'll be doing our year-end appeals coming up over the next few months, or give us a call. We'd be happy to help. So with that, I again thank you all and wish you a good afternoon.